Today's going to be like most first days where we're going to kind of be focused primarily on the functional anatomy kind of the system. Now, like I always kind of tell you all about, the first thing that you want to do whenever you're looking at a new system is first think back to everything that you think you already know about the system. So we know that the urinary system, like likely you probably already know that, well, that's going to include urine. And of course, our urine is going to include stuff like our urethra, that we store the urine in our bladder. Well, how does it get to the bladder? Well, it comes from the kidneys. Okay. Oftentimes people will say that the kidney filters blood. Well, that's fine for kind of the overview and kind of what we know like today, starting the chapter. But in the future, we're going to need a little bit more detail. Okay. So when we say that it filters blood, what we really mean is that we are going to remove particular waste products from the fluid of the blood. Okay. And then convert that into urine. Okay. Basically, this means that we are going to control what substances we keep in the blood and what substances we pass out of the blood in the form of urine. So we are going to be trying to control all aspects of this. We want to control salt. We want to control water. We're trying to control particular waste products, whether that's in the form of uric acid or something like that. We want to be able to get rid of things like all of the uric acid that we possibly can, while holding on to as much of the other stuff that we might need to hold on to as we can. So something like, say, glucose. We don't want to get rid of the glucose. We had to do a lot of work to get the glucose, so we don't want to get rid of it. So the question then becomes, how are we going to do this? Okay. Now, after we have made that urine filtrate, we've made that urine, we know that it needs to go to the bladder. We just have to have a highway to get it there. The highway that's going to get it there are going to be our ureters. Then we know we have the bladder. Oh, excuse me. And we know that it holds a variable amount of liquid at different times. You can receive the need or the urge to go to the bathroom with as little as 250 milliliters in it. But if you don't go to the bathroom right then, you can also hold it all the way up until it's about a full liter of urine. That is a big range. So the question then becomes like how we're going to deal with that. Okay. So here we have our primary structures. We, of course, have our kidneys. We have the renal artery and renal vein. So renal artery bringing blood to it. Renal vein, of course, going to be taking blood back away from it. A massive amount of blood gets routed into the capillaries, or gets routed into the kidneys. That's why these blood vessels here are so large. So we're going to have tons of blood in, tons of blood out. So these blood vessels have to be very, very, very large to be able to handle that. We then can follow out of the kidneys. We can then follow down to the ureters. This is basically going to be the little tube that's going to connect it to the urinary bladder. Now, notice that I did not just say bladder. That's because we have a few bladders in the body, namely, or primarily, we have like the gallbladder, which remember lives up here. And then we've got the urinary bladder down here. So you're saying bladder isn't quite going to be good enough anymore. Okay. And then, of course, we know that we expel the liquid from the urinary bladder through the urethra. Now, importantly here with the ureters, these are going to enter the posterior side of the urinary bladder, okay? Not the anterior side, not straight from the top. They will enter actually the kind of posterior side of the urinary bladder. Now, the urinary bladder, because it can expand from dealing with 250 mils or all the way up to a full liter of liquid, we also have to have some extensibility be found in that bladder. So we're going to talk about how we do that, okay? Now, giving our filtering the blood comment a little bit more specific. Wait, where'd my picture go? Oh, so help if I open my camera. So to put a little more specificity there, we are trying to eliminate metabolic waste. So the metabolic waste that we're talking about are going to be things like uric acid or urea. These are made from doing protein metabolism. Okay. So because we are breaking down proteins or utilizing proteins to do things, we are going to generate some amount of urea. We need to get rid of it though, because that's going to act as a poison to our cells. Once if we get too high concentrations, we need to be able to get rid of it. Excuse me. We're also going to use it to regulate the levels of many different kinds of ions, whether it's sodium, potassium, calcium. All of these are going to be important. When I say regulate, though, this means that we can determine when those levels go up and when those levels go down. Okay. So sodium, we know that we need sodium as a chemical messenger. Remember, it moves counter current to potassium whenever we're sending action potentials and things like that. So we do need it in order to have nerve signaling occur. We need it in order for muscles to work. The same thing goes for calcium ions. However, there is such thing as having too much sodium, because this is likely the case because you've probably heard someone on the news talk, or some diet person talking about, hey, you don't need that much salt in your diet. And the answer to that is you are probably correct. A single meal at McDonald's can usually have as much as 2 days worth of sodium in it. That is a lot. So we need to be able to get rid of any of that excess sodium that we have. The same thing goes for potassium and calcium. Now, this is not the primary way or the only way that we can regulate calcium. Remember that we can regulate calcium with our bones and stuff like that too. But this is just one of the ways that we can expel a bunch of excess calcium if we do happen to take some in. Okay. We're also going to be using it to change the pH of the blood. That's because, remember, we have this kind of bicarbonate ion buffer system in the blood. Well, say we have too much bicarbonate in the blood. We need to be able to get rid of that. Okay. So say our pH is too low, we need to be able to adjust that. And one of the ways that we can adjust that is actually in the kidneys. Now, this is not our preferred way. It's not by any means the only way that we're going to do that, but we will do it some. Now, regulation of blood pressure is also huge. We've already talked about renin and angiotensin. That's because the kidney is in the best possible position that you can possibly be in order to regulate blood pressure. Okay, that's because we are able to regulate many of these ions, which is going to be talking about how fast or slow muscles are moving, all kinds of fun stuff like that, including smooth muscles contracting and all that fun stuff. But also because it is going to receive a massive amount of blood all the time, and it can regulate how much fluid is going back into the blood. Okay, because it is able to regulate the fluid content of the blood, it is also going to be directly linked to regulating blood pressure. Okay, so we're going to talk a little bit about how it's going to do that too, but that is one of its big roles. And then also we can eliminate many different things. So what it's calling biologically active molecules, this could be hormones. So some amount of hormones are going to be water soluble, thus we can get rid of them via the kidneys. We can also eliminate some water soluble drugs and stuff like that. Excuse me. Oh, all of a sudden sleepy. Now, in addition to those, we also have some other functions. We're going to form calcitriol, which is going to be important later on. And the same thing goes for we can produce and release erythropoietin. This is another way of regulating blood pressure, but it's also going to help us deal with oxygen levels, primarily because erythropoietin, remember, is the hormone that's responsible for telling us to produce more red blood cells. If you increase erythropoietin, you're going to increase blood cells. Then we can also deal with gluconeogenesis. This is basically going to be saying, hey, blood glucose levels are low. We need to make new glucose. We're going to make new glucose from things other than glucose. Okay. So say you have a whole bunch of proteins in your diet. Well, you can actually make enough glucose from those that you can generate through this process called gluconeogenesis, generate the glucose necessary to maintain those levels. This is usually only going to happen during kind of prolonged fasting and stuff, like I said, or malnutrition. All right, so let's look at our kidneys. So first off, our kidneys are fairly low, okay? They are, of course, inferior to the diaphragm. They are also quite posteriorly located, okay? So they're going to be located lateral to the vertebrae, okay? So here we have the body of the vertebrae. So they're going to be lateral to those vertebrae. They're fairly low. You'll notice that one tends to sit a little higher than the other. the left is going to tend to be a little bit higher than the right. The reason the left is going to be higher than the right is because on the right-hand side here, remember that we have the liver, okay? So that large lobe of the liver is going to kind of force that right kidney to be found a little bit lower, okay? Now, I also want you to keep in mind that this is just on average. There are going to be variations both in where they are located relative to one another, as well as some variance even in just the number of kidneys that people have. Some people are just born with just one. And they may not know that until they go get an x-ray done or something like that. Now, here you can actually see the 3 levels of the kidney. So the kidney is going to contain this nice kind of fibrous capsule around the outside, making sure that it's separate from all of the other stuff around it. And then we're going to have the cortex, just like we've seen before, the medulla. The medulla is going to be separated into these little columns called renal columns, and then finally these big triangular shaped regions called renal pyramids. And then the entrance and exit for the ureters, renal arteries, and renal veins are all going to come from this kind of eye of our P here. This region here is going to be called the renal hilum. Okay, so we can see all of those. So now with this anterior view, it's a little easier to see. So here we see our renal capsule or fibrous capsule. We can see the renal cortex. We can see the renal medulla. Each of these renal pyramids is going to lead to this little structure here that we're going to call a minor calyx. Okay, so this is basically going to be the little pathway that's going to connect the renal pyramid to what will eventually become the ureter. Okay, but it's one small little tube. Now, when 2 minor calyces come together, so the little tubes from multiple pyramids come together, we're going to call that a major calyx. So now here, because we have the intersection of multiple minor calyces, we're going to call this a major calyx. That leads down into here what we call the renal pelvis, and then finally it will be into the ureter. Okay, but once any of the fluid reaches these calyces, it is just going to be straight urine. And we'll talk about that stuff here in just a moment. Now, importantly with our kidneys, like I said, we're routing lots of blood in here. By taking that blood in, what we're going to do is we're then going to route that blood through this series of vessels until finally it gets up here into the renal cortex. Once we get that blood up here into the renal cortex, we're going to then have that blood enter what we call our afferent arterioles. So here that blood's going to come in, and then it's going to enter this weird set of structures up here. This strange set of structures right here is actually called the nephron. This is our functional unit within the kidney. Now, each kidney is going to have millions of these, okay? So these things are minuscule. However, they are also going to make up the bulk of the kidneys. But like I said, this is the functional part. So this is actually where that blood is going to get filtered. Now, just like say if you were taking water that had coffee grounds in it and you're trying to run it through a filter, you have to have something that is acting as a filter, okay? So you can think about this afferent arteriole as basically being the coffee mixed with water, okay? We're going to take that fluid, so this is just blood, right? So we're going to route the blood into this big knot of capillaries here. Now, this big knot of capillaries is going to have these special little finger-shaped structures here that are going to kind of overlap like this, okay? Where the overlaps of these fingers and where these fingers are meshed together, we're going to try and capture a whole bunch of the large stuff in the blood and make sure it stays in the blood. So it's going to catch, going back to the coffee analogy, it's going to catch all of the coffee grounds, okay? And the only thing that is going to allow pass through it is going to be really, really small stuff and things that are dissolved, okay? So this is our filter. Now, we call this structure the glomerulus. So this knot of capillaries is our glomerulus. This is what is actually acting as a filter. It is basically stopping anything that is not the liquid in the blood and stuff that is dissolved in that liquid for moving out into this kind of collection area, which we're going to call the capsular space, because we're going to cover the glomerulus with what's called the glomerular capsule. That's basically this little ball of membrane that's around the knot of capillaries. So the knot of capillaries is the glomerulus, and it is surrounded by the glomerular capsule. Okay, so this way, the blood, cells, waste products, all that kind of stuff moves in, and then waste and liquid moves out here into the glomerular capsule, while the red blood cells and then the required amount of liquid that's required to move them through will then stay in the vessels and then leave the glomerulus out through what we call the efferent arteriole. Now, the afferent and efferent should sound pretty familiar, like when we were talking about nerve signals and stuff like that, where afferent was towards, efferent was away. So afferent arteriole is referring to bringing blood towards the glomerulus. Efferent arteriole refers to the fact that it's taking blood away from the glomerulus. Okay. Now, as we have that filtrate here in our capsular space, that fluid then is going to get pushed into a couple of sets of squigglies. Okay. This first set of squigglies we are going to call the proximal convoluted tubule. Proximal because it's close to the glomerulus, convoluted because it's really bendy and twisty, and tubule because, well, it's a tube. Okay. We have two of these. We have a proximal convoluted tubule, and then we have a distal convoluted tubule. Distal because it is further away from the glomerulus than is the proximal. Okay. So we're going to go through one big set of bends. Then we're going to go down this structure here where we're going to descend and then come back up this loop. Now, you'll sometimes see, or your book will refer to this as the nephron loop. You may see this in other books as the loop of Henle. Okay. So we have the descending nephron loop and we have the ascending nephron loop here. That's going to go down, usually crossing into the medulla for a while, and then it's going to come back up, and then it's going to go through this distal convoluted tubule, and then finally it's going to enter what we call the collecting tubules, and then finally into this structure, which is the collecting duct. That collecting duct will then go down into the minor calyx. So that's kind of our pathway here. Okay. So we're going to kind of break down the anatomy of these things a little bit. Okay. Like I said, with our glomerulus here, we have all of these cells in that ball of capillaries. So very, very thin capillaries are. That's going to stop some stuff moving through them, just the fact that we have the actual endothelial cells of the capillary. But then above those, we're going to have these special structures called podocytes. That is these cells here with these special little feet-like appendages where they're overlapping. Those are going to stop really small particles even from being able to get out of these capillaries. So making sure that as many things as possible, or that many different things are going to stay inside the blood here. The endothelial lining is going to catch large proteins and it's going to catch cells. That way we don't end up with blood cells in the urine, because that would be bad. They're also going to stop large proteins. The podocytes and then the pedocells on the podocytes, those are going to act as a bigger filtration barrier, so basically catching more fine stuff, and that's going to catch anything from even medium to small size proteins, making sure that those things stay inside the blood vessels themselves. And then, so entering, we're going to make sure that stuff stays in. So then we're going to exit. So this is going to make sure that through the efferent arteriole, you're going to find red blood cells, white blood cells, large proteins, small proteins, and some larger molecules like that. Okay. But then in the urine filtrate, this is going to be everything that's dissolvable as well as things that are small. So this is where you're going to get your waste products, your glucoses and stuff like that. Okay. However, we don't want all of that in there. Remember that, like I said before, we went through all this trouble to get stuff like glucose into the blood. We want to make sure we get that stuff back. It's usable. So what are we going to do? Well, this is where the proximal distal convoluted tubules come in, as well as the nephron loop. You see in our proximal convoluted tubule that we have a whole bunch of cellular extensions on the insides of these fairly large blocky cells. Okay. Now, these are all going to be simple cuboidal cells. But in the proximal convoluted tubule, these are going to have cilia, or not even cilia. Think structures that look like cilia or look like microvilli in them. Okay, so these large cellular extensions, so we get lots and lots of surface area, lots and lots of surface area, so we can have lots and lots of proteins. Because embedded in these membranes are going to be proteins that are going to allow us to absorb the substances that we want to keep. Okay. So like glucoses, there are going to be lots of proteins reaching out there so that we can pull in as much glucose as we possibly can and get it back into the blood. Okay. Because we don't want to get that stuff out there. We may also have some secretory proteins in here so that we can even secrete additional substances like more urea and stuff like that. So we can concentrate the substances that we don't want in the urine filtrate while also at the same time taking back up as much of the substances we want to hold on to as we possibly can. Now, then we're going to get into the nephron loop. Now, the nephron loop is going to have thick segments and thin segments. Thick segments are going to contain these larger simple cuboidal cells. The thin segments are going to contain nothing but simple squamous cells. Okay, so very, very, very thin barrier. That way things can quickly diffuse across them should we need to. So this is one of the places we're going to regulate stuff like water. Is going to be down here in our nephron loop. And then we're going to come back up here in the distal convoluted tubule where we will continue trying to absorb as much stuff into the blood as we want to hold on to, while also at the same time concentrating as many of the bad things as we want to get rid of. So we're going to try and get as much urea into our collecting ducts as we possibly can. Now, we do have two different kinds of nephrons. We have cortical nephrons, we have juxtamedullary nephrons. Cortical nephrons are going to be most common. Nephron loops are fairly short. Nephron loops, however, on juxtamedullary nephrons are going to be much longer. So we're going to be using these to help us regulate things like water balance and stuff like that. Salt concentration gradients and things, okay? Now, the capillaries associated with them are also going to be a little different, okay? So the capillaries associated with cortical nephrons are not really going to deal with the nephron loop very much, okay? However, we're going to have this special set of capillaries around the nephron loops of our juxtamedullary nephrons. We're going to call this the vasa recta, okay? So we're going to see this here in just a second, kind of look at its function as well. But that's one of the ways that you can tell them apart is basically the presence of this ladder-shaped set of capillaries dealing with the nephron loop down here. Now, if you were to look at a micrograph taken from the kidney, you're going to see lots and lots and lots of tubes. Those tubes could be something like proximal convoluted tubule. They could also be collecting ducts. They could even be segments of nephron loops. So notice that these are just open circles with very thin cells along their walls. That makes sense then that these are going to be parts of our nephron loops. Okay, so here, once again, opening, very thin layer of membrane around them. So that's going to be a nephron loop. This one is huge. Have this big structure here, including some with these kind of big finger shapes, but not all of them have it. So that's going to be one of our collecting ducts. Here's one of those blood vessels. So that's going to be part of our vasa recta. If you look at the proximal and distal convoluted tubules, the proximal convoluted tubules are going to be these circles where you can see lots of structures facing the inside of the loop, or lots of structures facing the lumen. Distal convoluted tubule, these square-shaped cells tend to be a little smaller, so notice that they're not quite as tall as these over here. And there's also going to be fewer cellular extensions. That's because most of that reabsorption is going to have taken place in the proximal convoluted tubule. Now, we're also going to see some structures here in what we call the juxtaglomerular apparatus. This means near the glomerulus. This is basically where the afferent and efferent arterioles are going to leave the glomerulus. This space in between, we're going to see these cells called macula-densa cells as well as some granular cells. All of these are going to be here to monitor essentially what's happening, looking at things like blood pressure and stuff like that. All right, so now we can look at the flow of blood, okay? So basically we're going to name some of these blood vessels that are moving through our kidney, okay? Renal artery. It comes in, it's going to branch into what we call these segmental arteries. We have two segmental arteries. Those are then going to branch, and then they're going to form into what we call the interlobar arteries. So the interlobar arteries are basically going to carry blood towards that cortex up here, okay? So that blood's going to come basically pass around one of those renal pyramids and start to get close to the cortex. Once we enter the cortex or we start running along the top of one of those renal pyramids, we're going to call it the arcuate artery, okay? Now, when those branch and actually get all the way out here into the cortex, we're then going to call those the interlobular arteries. Once we go from interlobular arteries, we are then going to enter. So here we have our interlobular artery. We're then going to enter what we call the afferent arteriole. So then we're going to go from afferent arteriole to the glomerulus. So that's the structure here. Then we're going to leave the glomerulus and we're going to enter the efferent arteriole, at which point this is the actual set of capillaries is where we're going to have our deoxygenation occur, okay? So now we're going to drop off oxygen into the tissues. Waste product tissues. Excuse me. And then take up things like CO2 and stuff like that. So that's why you're now seeing them drawn in purple or even blue, okay? Now, then we're going to start to pass around the proximal and distal convoluted tubules at the same time, okay? So we're going to see some parts of these paratubular capillaries around the proximal convoluted tubules and some around the distal convoluted tubules. Oh, no problem. Now, this is also going to depend on which type of nephrons that we're talking about. If we have one of these juxtamedullary nephrons where we have this large nephron loop, we will also be dealing with the capillaries around what we call that vasa recta, dealing with the nephron loop of those juxtamedullary nephrons, okay? Then we're going to enter the interlobular veins, okay? So we basically have now passed off all the oxygen and all that kind of stuff, so now we're in veins, so interlobular, so that means we're out here kind of in the cortex, okay? So here we have our interlobular vein, at which point it will come back into this crossing side to side. So remember, this is our arcuate vein, which will then pass back down the sides of the pyramids. So now we're in our interlobar vein. And then finally, we're going to enter the segmental vein, and then finally the renal veins here. Okay, so that's basically going to be the pathway that the blood itself is going to take. Now, the urinary filtrate is going to be something a little different. The filtrate starts here in that capsular space, so in our glomerular capsule, and then it's going to enter the proximal convoluted tubules, go down the descending loop of Henle, up through the ascending loop of Henle, and then finally through the distal convoluted tubule into the collecting tubules, and then finally into the collecting ducts. Now, once we enter the collecting ducts, we're going to pass down finally into a, it's going to call it a papillary duct here, and then finally into a minor calyx, and then finally into a major calyx, which remember is where multiple of those calyces come together. Then finally into the renal pelvis, into the ureter, into the urinary bladder, and then finally out through the urethra. So that's going to be the pathway for our fluid. Now, importantly here, we do have to deal with kind of what is occurring at our, or in these various regions of the tubules, okay? So the first step that's going to occur is going to be the filtration by the glomerulus. This is where we're going to move things from the blood into that capsular space. So it should just be small stuff, ions, sugars, stuff like that that are able to cross into the urine filtrate. Then in the proximal convoluted tubules, in the loop of Henle or in the nephron loop, and in the distal convoluted tubule, we're going to have what we're going to call tubular reabsorption. This is basically stuff where the tubes themselves are going to try and move stuff from the fluid back into the blood. So if we want to hold on to glucose, it's going to move from the tube into the blood. If we want to hold on to sodium, we will move the sodium from the tube into the blood. However, we will also see some cases of tubular secretion where we're going to move stuff from the blood into the tubular fluids. Like, oh, in the blood, we still have some amount of waste products. We're going to move as much of that into the tube as we can so it can be eliminated. And this is going to be happening, like I said, in proximal distal convoluted tubules, in the nephron loop, even in the collecting tubules and collecting ducts. We'll see some of that. Now, our filtration levels, so our filtration membrane is going to contain 3 layers. We're going to have the endothelium inside the glomerulus. So this is basically the walls of the vessels themselves. These are fenestrated, so they do have holes in them. So this is going to allow some stuff that's dissolved and things like that to pass through them. However, big structures like blood cells are going to stay inside the blood vessel. Okay. Now, the basement membrane of the glomerulus, so our capillary is covered by a basement membrane. That basement membrane is going to stop things like proteins from moving through it. Okay. So making sure that large plasma proteins like your albumins and stuff like that can't move from the blood vessel out into the filtrate. That's going to be important because it's going to help make sure that we keep at least enough fluid inside the blood vessel to keep the rest of the blood cells and stuff moving. We don't want it getting so much water getting taken out of it that there's no liquid through which the blood cells can move. So we need to make sure that large proteins like albumin, which remember hold on to water and make sure that the blood stays liquid, can do that. Okay. Then we're going to have above that, we have the visceral layer of the glomerular capsule. So this is outermost layer where we have those special cells called podocytes with those long processes called pedocells where those are going to overlap. And then the spaces between those pedocells are going to be what we call filtration slits. The space in between those pedocells is going to determine the size of the things that can pass through them. But these are basically going to restrict passage of everything that is basically the size of a small protein or larger. Okay, so amino acids, fat, excuse me, small proteins, fats, and stuff like that are going to have a really hard time moving through there. Some small proteins may bleed through. Some individual amino acids and stuff like that may bleed through. It will allow the passage of things that are dissolved, so ions and stuff like that. Allow that stuff to pass through those so that we can get it into the filtrate. So, endothelial cells is layer 1. Basement membrane for the endothelial cells is layer 2. And then finally, the podocytes, their pedocells, and the spaces in between those pedocells, the filtration slits, that's going to be our visceral layer. This is going to stop the movement of small proteins out. So then the only things that moving through, like I said, are going to be very, very, very small. So here's our list of things that we're going to find in there. Water, glucose, individual amino acids, ions, urea, which is that waste product we were talking about before. Some of our hormones, because remember, some hormones are those monoamines and things like that. Water-soluble vitamins, so things like B and C. Ketones, and then very small amounts of very small proteins. Now, you may wonder how much filtrate we are producing. We are producing as much as 180 liters of filtrate a day. That's a lot. I don't know about you. I've never urinated 180 liters in a day, nor should you. That should tell you how much reabsorption our body is actually having to do. We are reabsorbing the vast, vast majority of that. Oh, one thing I did not mention before is that if you are dealing with something that has a negative charge, it's actually going to have a fairly tough time moving through these filtration layers. So they are going to kind of basically stay inside the blood just simply due to that negative charge. Just as the nature of the pedocells and the way that the movement of these ions and stuff is going to cause. That's why when we were listing the ions and things that were moved before, the only one of those that you saw that had a negative charge was the HCO3. Everything else is going to be positively charged if it was able to move through this. That's because having large size or having some sort of negative charge can inhibit your ability to pass through. Now, pressures do matter here, okay? Because this is a filter, we need to understand that if you were to take, say, a coffee filter and pour water slowly through it, it's going to do exactly what it's supposed to do. It will stop the grounds from moving through. However, if you took a water hose to that coffee filter and just crank the water all the way up, it may actually allow some of those coffee grounds to pass through. Why? Because the water could just simply break the filter. Which means if we don't want to break our filter, we need to make sure that we are maintaining the blood pressures that are moving through here. Because of that, in order for the kidney to work correctly, the kidney has to be able to regulate the pressure of the blood into this glomerulus. So we're going to be able to do that by constricting or opening the vessels, or constricting or opening the afferent arterioles. If we open it, we can decrease the amount of pressure that the filter is going to feel, or we can close it and kind of vice versa. Okay. Open it will move more fluid through, but at a slightly lower pressure than we will if we kind of constrict it and stuff. Okay. But all of this is for us to regulate this glomerular filtration rate. We want to make sure that we can regulate it, make sure that we can keep it as constant as we possibly can. Because of that, we will regulate or upregulate or downregulate how much fluid, how much fluid we are going to hold in the blood. More fluid means we're going to have higher blood pressures. Less fluid means we're going to have lower blood pressures. So if the kidney is seeing chronically high pressures, what they will do is they will cause us to get rid of excess fluid or get rid of extra fluid, thus lowering blood volume, thus lowering blood pressure. That's why we need to be able to adjust these things. Okay, so under normal systemic blood pressure, we're just going to leave things nice and normal. But under an increase in blood pressure, we'll actually constrict the vessel here. Okay, so we'll actually constrict the afferent arteriole so that not as much fluid at this high pressure can come in. Under low blood pressures, we'll basically open the afferent arteriole to allow more blood to push through. That way we can push more things into the filtrate, because it's going to be basically forcing the blood pressure itself is going to be what we're using to force stuff into the urine filtrate. Now, if you have chronically high blood pressure, this can also actually start to cause problems with those pedicels and actually cause problems with that filtration membrane, at which point, not only will you have an increase in urine formation, you can also start to stress that filtration membrane and start to cause problems with overall kidney function if it stays there for too long of a time. Now, back to our proximal convoluted tubules. Notice that, like I said before, we have simple cuboidal epithelium that we're going to find in both our proximal and distal convoluted tubules. Now, in the proximal convoluted tubules, we're going to have lots and lots of these membrane extensions so that we can have lots and lots of absorption and secretion happening here. Okay. Now, we are going to need to move things across the membrane, sometimes even in between the cells. If it's moving in between the cells, we're going to call this paracellular transport. So basically through the spaces between those simple cuboidal cells. Other times we're going to need to move things through our membrane embedded proteins, like you might see here, which we might call transcellular transport. A bunch of this is mostly just physiology stuff. That's why I'm trying to skip through it a little bit. Not that I don't have videos already talking about it, but also just because I'm trying to have this one be focused primarily on the internet. Now, throughout all of these, you're saying that the vast majority of the reabsorption of most of these things is going to occur in this proximal convoluted tubule. However, in none of these things so far has all of the reabsorption been done in the proximal convoluted tubule. However, if you look at something like glucose, only in the proximal convoluted tubule can glucose be reabsorbed. So we're going to see big differences in some substances and where we are going to be reabsorbing them. Most of it is always going to occur in the proximal convoluted tubule, but you'll notice that we're seeing numbers ranging anywhere from 60 to 80 to 90 in some of these cases too. So each individual substance is going to be a little bit different. All right. Oop. Now, once we have formed all that urine, we're then going to get it or need to move it to or from the kidneys to the urinary bladder. We're going to do that through the ureters. Now, the ureters are going to contain a very thick layer of mucosa, where we have this first layer, which is our lamina propria, and then finally we're going to have this set of tissue down here, which we're going to call transitional epithelium. Okay, so lamina propria up here, and then we have this layer of transitional epithelium as we're getting closer and closer to the lumen. Now, in addition to having transitional epithelium here, we're also going to find these little folds of the mucosa in here as well that we're going to call a mucosal fold. So folds and transitional epithelia. What does this mean? Well, we use transitional epithelia when we need to have stretch. Folds are going to allow us to have additional stretch because the folds will basically flatten themselves out and then they'll actually stretch the transitional epithelia. Why might we need to do this? Well, this is because in addition to just simply moving fluid through the lumen of the ureters, oftentimes we don't go to the bathroom even when we receive the signal that we need to go to the bathroom. Say you're on a road trip or something like that. You drink a soda right at the beginning of the road trip. You're like, I don't need to go to the bathroom right now. I'll just hold it until we get to where we're going. And say you're driving out to, I don't know, past Dallas or something like that. So you're driving to Houston. It's a 3-hour drive, 4-hour drive. Well, over that time, you first get that signal that you need to go to the bathroom once you hit 250 milliliters or so from your urinary bladder. But it will continue adding fluid from your kidneys during this entire time. So say you drink a 44-ounce liquid, so Route 44 or something like that. Well, a liter is only like 32 ounces. So you've gone past that and how much fluid you're going to pass. So what happens to all that liquid? Once the urinary bladder is full and you're still not relieving the pressure on it, where does that liquid go? Well, that liquid will actually back up in your ureters themselves. So our ureters have the ability to distend just like the bladder does. So your ureters have the ability to kind of expand out and hold on to additional fluid as well. So you are basically able to act a little bit like a reservoir for the bladder in cases where you say don't go to the bathroom quickly enough. However, because of that, something else fun will happen. Namely, once we finally relieve the bladder of its pressure, so say we have built up our 1 liter of fluid right here in our bladder, we finally release that through the ureter, you'll need to go to the bathroom almost immediately. Like, so if you've ever done a big road trip like that, like where you've waited 2 or 3 hours to go to the bathroom, and then you finally do go, like to the when it was at the point like where it was painful or something like that, you get back in the car and it's almost like you need to go to the bathroom within moments of having already gone to the bathroom. Why? Well, that's because you had so much fluid built up in your ureters up here that fluid immediately drains from your ureters after you've emptied your bladder, and it starts to fill back up, and it fills back up to the point where you're already getting the signal that says, hey, I need to go to the bathroom again. That's because your ureters are holding on to enough fluid that when it gets released into the bladder that you're receiving the signal that you need to go to the bathroom already. Because you receive that signal from the bladder, like I said, once you hit 250 milliliters or so, which is not very much, okay? Now, to help the urinary bladder do its expanding, we also have these folds of the mucosa on the lining. We're gonna call these folds up here, or we have these mucosal folds here inside the bladder, once again, so that those can distend. And then inside the mucosal folds, so the actual mucosa of the urinary bladder, once again, is going to be composed of that lamina propria and transitional epithelia. Okay, so that transitional epithelia, remember, can be stretched so that as the bladder expands, the epithelial tissue is still able to act as a good barrier. Now, in addition to that, it's also going to be composed of muscle. Primarily, it's going to be our destrusor muscle here. Okay, that's going to be our primary muscle from the bladder, so that whenever we do go to the bathroom, we can kind of squeeze that muscle, and that's going to help us push out the liquid from the bladder. My goodness. All right. Now, then we get to the urethra. Now, the urethra is basically going to have a couple of openings inside the bladder, at which point the fluid goes into those openings and will then push through the urethra. One of the signals that we get that we need to go to the bathroom is actually going to come from this internal urethral sphincter here, which is basically going to be at the base of the urinary bladder. As we fill this with fluid, it's going to put some amount of stress on this internal urethral sphincter. Basically, it's stretching those muscles a little bit to where they're going to start to send the signal that says, hey, I need to go to the bathroom. Okay. And it's going to be the stretch on those that is what's going to send that signal. And it will continue sending the signal until you have gone to the bathroom and relieved yourself. Now, whenever you go to release the urine, what you're actually going to do is you're going to relax this muscle here, which is your external urethral sphincter, which is actually finally going to release and allow the fluid to leave the bladder out through the urethra out to the external urethral orifice. Basically, that's to say to the outside. Okay. Now, this is in females where we have a short urethra from the bladder out through the external urethral orifice, at which point it will pass by some of the external genitalia and things like that. That is going to be a little different than in the male urethra. In the male urethra is much larger. It's going to pass through several other structures before we get to that external urethral sphincter, which is here. Namely, it's going to pass through our prostate. This is actually one of the reasons why issues with one's prostate, so say you have prostate cancer, why one of the reasons that, or one of the symptoms of prostate cancer is actually going to be inability to urinate or weak stream of urine, will be because that is going to cause problems in the prostate, at which point it will cause a constriction on the urethra. So you have a harder time getting fluid or draining the bladder completely because of the proximity of the prostate to the urethra, because the urethra quite literally passes through it. Now, the reason that the urethra passes through the prostate is because during intercourse, the prostate will actually be secreting some hormones into the ejaculated fluid. Okay. Because of that, it has to be here basically positioned around the urethra in order to get that fluid to go through that pathway. Okay. Now, the urethra that will then go through our external urethral sphincter and through this region we call the membranous urethra, because it's basically passing through this membrane and muscle segment. And then it will enter the spongy urethra because we're passing through now the penis, and then finally out through the external urethral orifice. Now, because this is not releasing so close to, say, the anal canal as it is in females, because the penis is basically acting as a buffer, so basically making sure that the urine is passing through an area further away from the anus, what this is going to mean, there's going to be a much harder time for any of the bacteria from around the anal canal to make their way to the external urethral orifice in male. Because of this, males very rarely have urinary tract infections. Females, because of the proximity of the external urethral orifice to the anal canal, they are going to be much, much more subject to having urinary tract infections, where they are quite common. Now, that is basically going to be it as far as the anatomy for our urinary system. The rest of the stuff related to our urinary system are going to be primarily dealing with physiology within the system. So like I said, on Wednesday when we come in, we will talk about the substances that we're moving in the urine, things that we should find or things that we shouldn't find in urine. We're going to do that by doing what we call a urinalysis test. Also on that day, I will talk about the teamwork writing assignment on there, where we're going to write a lab report over the urinalysis test that we're going to be doing here in class. So if you have any questions or anything like that, please just let me know. All right, thanks. See you soon.